Okay, so welcome to episode 4 of the eyecare.education podcast. And this week's topic is all about dry eye. So we've got a few dry eye experts with us today. We have Ros Mussa, who is a CLO. We have Francesca Marchetti, who is an optom. And we have Peter Charlesworth, who was on episode 2 as well, who's an optom and also a dry eye sufferer. So first of all, we're going to just get to know Ros and Francesca a little bit better and hear a bit about their story. So if we start with you, Ros, could you just give us your sort of background into optics, how you got to where you are today, what kind of stuff you've been up to in the industry? And I think you've got some quite important news to tell us as well, haven't you, about something you've recently been awarded to. You can drop that in as well.
Oh yeah, all right. Yeah, so good morning everybody. My name is Ros Mussa. I'm a contact lens optician and therefore I spend the majority of my working day in practice in the City of London. I not only, apart from working in practice, I've also worked on teaching faculties and I'm accredited at giving peer-to-peer, working at City University, working for the likes of Alcon and Scope Ophthalmics. And I think when you're a contact lens optician, you spend the majority of your life looking down a slit lamp, and there's a huge conversation, isn't there, about penetration rates of contact lenses in this country, along with dropouts. And dropouts are something that I have a little bit of an issue with, because I kind of feel, rightly or wrongly, that maybe we've got a little bit lazy because we've got such good materials that what we tend to do is just refit. But actually, if we looked at what's causing the underlying problem and then actually fix that along with refitting, you'd probably find that patients wouldn't drop out as much. So that's my interest in dry eye, because actually everybody's anterior surface it's the only part of the globe that's exposed to the environment, and therefore is going to kind of sustain some sort of environmental influence. If we manage that well, then actually they'll stay in their contact lenses. Apart from that, the news that I've got is I've been awarded the Freedom of the City of London, and that's it's quite a lot of fun. It's really nice, and I feel pretty privileged to have that. So Thank you for inviting me along to the podcast today.
All right. So what do you actually get with the Freedom of the City of London? What's involved in that?
Well, basically, apparently, I get to drive sheep across London Bridge. It goes back. It goes back quite a long way. It goes back to when all the trades had their own livery, their own position, and once you had become free of the City of London, it meant that you actually had the right to practice your trade in your own name, and you didn't have to be an apprentice. Right. So it was quite an honour. It could only be given to somebody that was quite respected and very proficient in their trade, and of good character as well. So it's got a long history. It's some of the beautiful buildings in London that you don't even realise that are there are actually some of the livery halls, and each trade has its own post or own place. So it's pretty special. It's very nice.
Congratulations. Quite an achievement. So all you need now is some sheep.
I need some sheep and a big key, because that's what it means. You've got the freedom to drive your sheep across across London Bridge, as opposed to having to surreptitiously get them across the river somehow or another.
Yeah, definitely. Sounds like a challenge anyway. So how about you, Fran? Do you want to give us a bit of a background, your sort of journey into optics and what kind of stuff you've been doing recently?
Yeah, I feel very underwhelmed now. You'll feel very underwhelmed by me. I think I probably partied far too hard when I was at school and didn't quite meet the grades to do medicine. So then I started looking around at what else I could do, and looked at dentistry, pharmacy, optometry, and actually went to do optometry and have never regretted a minute since. I'm passionate about my profession. I love my job with a passion. And actually right now, irrespective of financial issues, I'm really missing being in work, because I actually really enjoy my job. I'm a self-employed independent optometrist. I work for both multiples and the private sector. And so I do normal routine eye examinations, but I also do a lot of contact lens work. And depending on which area I'm working in, then I do quite a lot of MEX appointments where I do see a lot of dry eye. But I've just generally got a genuine interest in dry eye when it all started raising its head, probably 10, 15 years ago. And I thought, yeah, this is a problem here. And I just love it. And I love seeing the satisfaction that I get when I can sort patients out.
Mm-hmm.
And sometimes some of those patients are conversations you're having in the pub or in the restaurant with your mates or your gym buddies or whatever, and some of it's actually at the coalface in the practice.
Yeah, definitely. And although you haven't got been awarded a library, you do have a famous daughter, don't you? So that's something you can be proud of as well.
Yes.
So how about
Thank
you,
you.
Peter? What's your interest in dry eye?
So I am an optometrist, but I don't work in practice. I haven't worked in practice for 6 or 7 years, I think, at least. So my knowledge, I still work in education. My knowledge is increasingly theoretical about all sorts of things to do with optometry. But I have quite a practical understanding of dry eye because I have dry eyes myself. So I am fairly sure that I have Sjogren's syndrome. My GP disagrees, but Sjogren's syndrome is very difficult to diagnose. I think I've probably had it for about a year. I'll tell you a bit more about it as we go on, I guess.
Excellent. We'll look forward to hearing dry eye from a patient's perspective, definitely. So I suppose the first thing we want to look at then is what's actually contributing to this dry eye problem in the modern world. So it's like Fran mentioned, sort of 10, 15 years ago, you saw that it was going to become a big issue in the modern world, and something for optometrists and CLOs to be a lot more aware of in practice. So what do you think is sort of driving this dry eye situation at the moment?
I just think increased awareness of it. I think, I'm thinking back to when I first qualified, and the advice that I was giving to patients then was put a plant on your desk or a saucer of water on your desk to keep the atmosphere around your computer and your typewriter, as it was then, moist. I mean, that's the kind of advice you were giving people, which is a bit scary actually, but and then I think it's the digital technology where we're looking at computers more, we're looking at smartphones more, iPads, we're driving more, we're actually doing a lot more staring all the time. And I think, just the nature of the beast of everything is the fact that, we don't take time to drink enough fluids and we're staring at screens, etc., etc. And I think that's why there's been an increase in dry eyes. Also, there's lots more folk on more medications for lots of things. And a lot of the side effects of a lot of the medications are dry eye issues.
Yeah, definitely. So what kind of medications particularly lead to dry eye issues that you're aware of?
Well, I think just about everything that most people are on, the typical blood pressure medication, certainly antidepressants, the thyroid medication, the anti-acid medications, just about everything, to be honest. And some of that is also the systemic stuff that's going on too that causes dry eyes, contraception, HRT, all that kind of thing. So I think with every form of medication, you're robbing Peter to pay Paul. And I think a lot of these medications it's listed as a side effect on most of these. Some people suffer a lot more than others.
Yeah, definitely. So, and again, you sort of, like you say, you're sort of robbing Peter to pay Paul, aren't you, in the sense that you're treating one ailment, but you're kind of contributing to another one.
Yeah.
So what about you, Ros? I mean, you've obviously worked for some of the bigger companies that are involved in sort of dry eye products and things like that. So what kind of information do you have coming out of there in terms of the background of their products and sort of how does the UK market compare with other parts of the world?
Well, as far as our products go, it's interesting. I was listening to a podcast just the other day from some run by is actually some American ophthalmologists that are very, very interested in dry eye, and it's interesting that they're fighting quite hard to get products that are preservative free, because most of their products are actually preservative based, and that's causing a huge problem. And they were quite interested to note that most of our products in Europe and the UK especially are without preservative. And that to them was just a massive, huge step forward in just managing dry eye. So just taking things out, and I think this comes back to Francesca's point, that there's so much medication that people take that destabilizes the tear film. And if you can just stabilize that just by using a proficient drop that hasn't got preservative in it, that'll make a massive difference. And it does, and I see it myself in practice because we run a dry eye clinic alongside and in conjunction with the contact lens clinic, and it's incredible just what one small change will make.
So what difference does the preservative make? So from a layman's perspective, if I was a patient coming to practice and I was deciding between, you know, this drop or a drop that's preservative free, how would you explain the difference in how they actually work?
How I explain it to a patient is when you put preservative into a drop, it's a bit like changing the salt level in the drop, and it's a bit like a salt burn. I mean, that's not accurate, but they can kind of relate to that. So, and if you think about it as well from our contact lens solutions points of view as well, if you've got somebody that has got dry eye, you don't really want to put them on a multi-purpose. You'd rather put them on a hydrogen peroxide system, because they're putting something that's very pure into their eye from the contact lens. So that makes life a lot more comfortable. And you do find that patients can wear their lenses that bit longer and generally feel a lot more comfortable when they go in. Because if you're putting something that is a little bit unstable onto an unstable tear film, then it's just going to cause more problems.
Yeah, definitely. So who are these patients that you're seeing? Is there a particular demographic, or is there a particular type of patient that's more susceptible to dry eye issues?
I mean, obviously you have your glaucoma patients. So a lot of those guys that, and I am seeing a lot more patients coming into practice where they're changing their glaucoma drops to non-preservative. So that is making life a lot better from a comfort point of view. I think there's a particular medication, a bit like Francesca, because I'm missing being at work and I can't think as quickly. I can't remember the medication, but there's a particular glaucoma drop that is now being used, which is a lot more comfortable, but is making the eyelashes grow a lot more. So we're getting a lot more entropion. So I'm having to pluck those guys out. But other than, which we just had the other day, but other than that, generally their eyes are feeling a lot more comfortable and not getting the irritation that they would have been getting from their glaucoma drops. So that's one. The kind of area that I work in, I see a lot of judges, a lot of barristers and a lot of bankers, and these guys are working really, really long hours. They're pretty experienced in what they do, so they're a little bit older, to be honest, and they're on all sorts of meds, to be perfectly honest with you, and their lifestyle probably isn't the best. They may drink a little bit more than you should do, and all of that kind of stuff. So the influences that brings to the front surface of the eye is quite obvious, and you can really make a difference to that just by doing in-office treatments. And teaching them how to manage the situation a lot more better, and it does massively improve the quality of life.
Mm-hmm. Yeah, definitely. So how about you, Fran? What kind of patients are you sort of seeing on a day-to-day basis when it comes to dry eyes? Do you think
everything? Yeah. Absolutely everything. And I think what's also really important at the moment, we're seeing younger and younger patients, and some of that is because of the amount of digital devices that even children are using. So children are presenting for an eye examination complaining of sore eyes. Their mum or dad has brought them in because they've got sore eyes. Yeah. And you're trying to say to the parents of a 12-year-old, well, actually your 12-year-old is suffering from dry eye syndrome. So we're noticing it like throughout. And I think, as Ros was talking about, the lifestyle, people are not drinking enough fluid normally, so they're not keeping themselves hydrated. People are maybe drinking a wee bit too much, or not eating the right foods that are full of foods that are full of hydrating substances. So I think it's a knock-on effect, environmental, digital, and as I say, I'm seeing patients from very young to very old, and obviously the rationale behind their dry eye is quite different from a young person to an older person. And Ros did touch on the management. You know, I see patients who've been suffering from dry eye for years. They've been on hypermelos from their GP. How often do they use their drops? Oh, I use them once a day, maybe twice a day if my eyes are feeling uncomfortable. No, you know, if you need to use them 25 times a day, you use them 25 times a day. So I think it's giving patients the right amount of advice, the right management, and dealing with their expectations. And when patients say, oh, I'm not buying any more drops, none of them work, tried them all, none of them work. No, that's because you're not using them properly.
Yeah.
My favourite analogy for using drops is suntan lotion. You don't lie on the beach all day and then once your skin starts to burn, you put your lotion on. You keep yourself topped up all day long so that you don't get to the point you feel you need to put suntan lotion on. Exactly the same with the dry eyes, and they get that. They absolutely get it.
Yeah, definitely. So when it comes to a sort of a treatment plan for patients, what factors sort of influence your treatment plan?
You speaking to me?
Yeah.
Anyone?
I'll let you start, Ros.
I tend to, for me, I tend to look at what it is. It's quite specific. The treatment plan is very specific to each individual. So it may be that during the week they have to use their drops more, or they have to use their eye bag more, or they have to so sometimes I will say, I will take a particular patient, and if they're working really long hours and they're working harder than usual, or they've got a case coming up, we kind of know that that's going to push their dry eye further. Does that make sense? So it's about telling them that actually this is what's going to happen in this particular situation, and this is what you need to do to manage it in order for you to feel comfortable and look presentable as well. So it is very specifically targeted to the individual. I also give them my email address. I've got a work email address, and so they can email me anytime saying, this is what's going on, this is what I'm not happy with, is it normal, is it not normal? So it's almost like a bit of a hand-holding process, and that's kind of how we approach it. We also do a lot of in-house treatments. So we do a lot of plugging, we do a lot of Blefex treatment, you can do Mibaflow, you can do whatever you need to do. So it's also about saying to them, look, you know this event is coming up in your life, you know this is what triggers it to be worse, so come in just before that and we'll do a treatment to make things more comfortable through that process, and then I'll see you again after that. So we target it to the individual, to their lifestyle, to what's specific to them, also the systemic issues that they may have, trying to deal with their hay fever before it even becomes a problem. All of those kind of things is something that we really look at and manage. And I think JEWS 2, if you look at JEWS 2, it gives you a pathway to help that happen as well. So there is a system and a protocol that is now coming into place to support that for the individual, as a practitioner, to support the individual.
Yeah, definitely. I think I was going to mention the JEWS 2 report and just sort of get your thoughts on that as well, in terms of the impact that's had on the industry in terms of tackling dry eye.
For me, I don't know whether you want to talk about this later, but for me, it was actually quite interesting, JEWS 2, because it actually gave us an understanding of what's occurring to the system, as in there's hyperosmolarity, and so the whole system is coming apart, as opposed to actually it's not patient specific. And it's still interesting to notice that it is not, I think it was 1995 that it changed from a syndrome to a disease, and it's still being upheld as a disease as well. So it's still being recognised as a chronic disease that has to be dealt with. I think for me that was quite a seminal moment, because it made me realise that, or it underlined for me, this is something that is actually a real problem, and we can't change it, but we can definitely manage it.
Yeah. So how did that really sort of affect your thinking on it, and what difference does it make from being a syndrome to a disease? What's the sort of the severity of that?
I think as a profession, for me, it made me think, okay, this is a real problem. This is a real every disease has its, whether it's arthritis, whether it's most of these autoimmune diseases out there, like MS or whatever. There's a lot of people that wander around out there with these conditions, and it's actually the subtle differences that their management makes that keeps them going in day-to-day life. And that made me realize that actually dry eye is exactly the same. It's a real problem, and we can actually make its comfort a lot better. And that's how it made me think about it. It kind of made it fall into those categories for me, into the MS, into the Crohn's disease, it made it fall into those categories for me. And it made me realize that if I manage them, I could make the comfort of this a lot better.
Yeah, definitely. So you also mentioned a few other treatments that you do. So I think in standard practice, there's an arsenal of drops, eye bags, supplements, things like omega-3 and stuff like that we can recommend to patients, gel tears, etc. A lot of the usual sort of over-the-counter stuff that we can attack dry eye with. But do you want to tell us a bit more about the other treatments that you do as well?
The Blefex and the punctal plugging and that kind of thing. So we do a lot of Blefex. We do a lot of Blefex, and we do quite a bit of punctal plugging as well, purely because it's we all know we should be drinking more water, and we all know that the level of concentration, our concentrated tasks has gone up quite a lot, which means our blink rate is a lot lower. So with the best will in the world, if I'm seeing 16 patients or 18 or 19 patients a day, the amount of times that I have time to stop to drink water is actually pretty minimal, even though I'm feeling thirsty. But I've got my next patient sitting out there, my computer's pinging to say that they're there. I haven't got time to stop. So it's a way of helping them manage. It's a way of helping the patient manage so that they don't have to stop their busy day. And that's why these in-house treatments are so important, in my opinion. So it just means, for example, if you reduce the amount of drainage rate, because we're losing so much aqueous through evaporation, because that lipid film isn't there proficiently because we're not blinking enough, and we've got heat coming off the screen making that aqueous evaporate even quicker, and the aperture's even wider open. If we reduce their drainage rate, then we're going to keep more aqueous on the front surface of the eye. The eye's going to whiten, the contact lens is going to feel more comfortable if they wear them, or just generally they're going to feel better. And that comes with the punctal plugs, or as I like to call them, filters. I kind of give the analogy of a wine filter, to be honest. It just reduces it just puts a little bit more air into that wine as it goes through, and it tastes a lot better, and the eye feels a lot better and looks a lot better. So, and the Blefex is just, that's probably one of the best treatments that is out there. It's really easy to use. It cleans up the blepharitis really well. It cleans the lid margins better than any eye bag could ever do, to be honest with you. And it just gets everybody back to zero. And then they can do their own management on top of that as well. So it really aids somebody's ability to feel comfortable and manage dry eye.
Definitely. And I think, like I say, when you're giving advice for dry eye treatments, just general advice that you give in practice, you're asking people to change their lifestyles, aren't they? You're asking people to make wholesale changes to things that they maybe do because they find it difficult in those situations anyway, like yourself with, staying hydrated at work, it can be quite difficult. So having treatments that can take away that need and give them a better starting point going forward is definitely a good option. So what about from your perspective, Fran? What kind of treatments do you offer in practice, and what kind of procedures do you go through?
Well, depending on where I'm working, one of the practices I do work in, which is a private eye hospital, we do Blefex and other IPL as well. I think a lot of it depends on people's finances. Obviously, Ros, you're working in the city and you're dealing with maybe different demographics. If I'm working in the outskirts of Coventry, where most people are on income support, they're not going to want to pay for treatments. There's sometimes even reluctance to buying a £20 eye bag. And sometimes that's also quite difficult because I have to discuss things like warm flannels. We know that they don't work for all the reasons that we know an eye bag does work, but I have to give them that option first of all, and then if they find the hot flannels are not working, they may come back later and buy an eye bag. So I have a little bit of resistance from a financial point of view, where I'm with the MEC scheme, they will be seen under the NHS, and I will spend time with them and advise them to do this, 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 and this. It's then, will they take that message home? Will they actually adhere to it? And one of the things I do like to do in practice is have a follow-up appointment in 3 or 4 weeks' time, because it allows them to really adhere to what they should be doing. And then I said, like, come back and see me in 3 weeks, and then we'll do a telephone conversation. Let's get some feedback from you. So they've got some accountability on that. In an ideal world, I'd love to do BlephX on everybody. But financially, I think there are restraints, and sometimes the practice don't want to invest in the equipment that you're working in as well, because they just won't get the take up. But, in an ideal world, it would be a great thing to offer. But I think you then have to look at, what's the best workaround you can do.
Yeah, definitely. Like I say, you've got more actions, haven't you? But so carry on, Peter.
I was just going to say, one of the things that I found is that it takes a while to get on top of dry eye and what it is that works. So I think patient education has to be important, because you can't just say to a patient, well, this is what you need, do this, and you'll be okay. Obviously, as an optometrist, I have a reasonable understanding of dry eye. I don't think I'm a specialist in dry eye. I certainly have never done BlephX or ITL or any treatments like that on patients. But I know about eye bags. I know about the various different drops we've got. And Francesca, you talked about hypermellows. But, we've got such a wide range of different drops with different things, which are far, far superior to hypermellows these days. And I'm kind of glad that I've got dry eye now, and I haven't got dry eye 20 years ago, because now I've got a whole bunch of things that I can do. And I've just been messing about, doing different things to see what works. And some things work really well, and some things that I didn't think would work really well. So I thought, drinking water, yeah, right. When I'm thirsty, I drink water. What's that going to do to my eyes if I don't drink water regularly? Well, I tell you, it's probably the most important thing. If I don't I have to remind myself, I have to drink before I get thirsty. And if I don't, then my eyes get dry, and they get dry for 24 hours or more. So, if I get dehydrated during the day, then that night, my eyes are just terrible, and it wakes me up in the middle of the night. And, I have to put drops in the middle of the night. Whereas if I drink water, I'm fine.
Mm-hmm. So if I can just come back on that, I think you're talking about patient education. I think in my initial when I'm doing a full dry eye assessment, I would say that I do spend the majority of that appointment telling them what it is, why it is, showing them some pictures on the internet, giving them the College of Optometrists leaflets on blepharitis and dry eye to take away with them. And that's one of the reasons I like to do the follow-up, either via the phone or with an appointment, because it gives the patient accountability, and they will adhere to a program. If you just send them off, on you go, you're not going to get anywhere with that. So, and again, that's all part of the education process, which maybe some practitioners are not happy to do. If they're not being paid for a follow-up appointment or a triage telephone appointment, you just think it's just to get the buy-in from the patient, because ongoing it is practice building.
I think I'll endorse that on you, Fran, because I get exactly the same. We do a two-stage appointment. It's your initial, we treat it a bit like a contact lens fitting, actually. So we do, and even putting the drops in is actually done as a teach appointment. So because it's really important, if you look at the different dispensers that are available, that they're not all squeezed, some of them are pumps. You've got to look at the manual dexterity of the patient, because this drop might be amazing. It may be the best thing since white slice spread, but if you can't get it in your eye, then what's the point? So you're right, a lot of time has to go into educating the patient. A lot of the appointment is about explaining why they're getting the symptoms, how they're going to make it better. And if it doesn't happen, if they've honestly adhered, which is what their follow-up appointment is about, if they've honestly adhered to everything and things aren't feeling better, then something somewhere's gone wrong, and we need to know about that. So we need to know about that as clinicians, and they need to know why as patients, so that they can deal with this going down the line. And that's how we approach our appointments, really. And I think that's helped quite a lot, especially at this time, because I think I was saying to you, Stuart, wasn't I, that we haven't, the majority, we haven't had very many phone calls about problems in the practice at all, or the practices rather, but the majority of them have been, which have been about 7 so far, 90% have been dry eye, of which 50% have actually been not our patients. Right. So they've been coming from elsewhere, you know, finding us somehow or another and phoning up going, this really hurts and I don't know what to do. What should I do with it? So that's been quite an interesting thing. And when you're talking to the patients more, you can hear that they've, and I think this comes back to your point, Fran, that if you've done an initial, but you're not being paid for the next appointment, or you're reluctant to do it for whatever reason, then that understanding and that follow-up hasn't been there. And that's why these people are getting into a little bit of trouble, especially at this time.
Yeah, definitely. I also think when it comes to drops particularly, I think professionals need to have a better understanding of what's special about that drop that they're recommending.
Yeah.
We've run a few different sort of dry eye peer reviews, and dry eye situations have come up in various sort of CT scenarios that we've done. And we always, you know, ask the question, what would you recommend in this situation? And people would always say, I'd recommend artificial tears. But then we ask the question, which ones are you going to recommend? Why are you going to recommend that? Why are you going to recommend a Hycosan or a Clinitas over a blink drop or a Sustain, etc.? And I think from a dispensing optician point of view, if I'm recommending a type of varifocal or a type of frame, I'm explaining the features and benefits of those frames and lenses to that patient and why that is relevant for them. But I think people need to understand more about the actual drops that they're recommending too, in that sense.
Yeah. I agree. I think you have to, I think you have to know why you're I agree with you absolutely, because you have to understand what what you're expecting the active ingredient to do to that tear film. And so therefore, if it doesn't work, if this is what you're expecting of it and it hasn't worked, then why hasn't it worked? Have they not been using it properly, or has there been something wrong with your assessment? And that's fine, because we do get things wrong, as we do as DOs, we do, you know, we can get things wrong, but it's important to understand how we've not established what the problem was and why this hasn't actively worked. So you don't have to know every drop on the market, but you do have to kind of know, you've got to have one drop that you know will deal with aqueous, that will deal with lipid problems, that will deal with a combination of both, and why you're changing things, because you'll take your patient with you, they'll have more of an understanding, and they're more likely to come back to you as well. Yeah. If that makes sense.
Yeah. I think the analogy with varifocals is quite a good one. You know, you have a handful of go-to varifocals that you'll use first. Same with contact lenses, I guess. You know, that's a good analogy. You've got a handful of contact lenses that you'll use first, and then you've got other ones that you use to problem solve depending what the problems are. But I guess it's a bit like contact lenses and varifocals in that it's individual to the person, I think. You know, so I've tried all sorts of different eye drops, and I'm lucky I can go and blag some at conferences and things like that, and then try all the different ones. And you know, there are some that theoretically should work and don't for me, but they probably do work for other people. So you know, I settled on, having tried all sorts of different ones, I settled on one that I know works for me. But you know, what works for me is not necessarily going to work for other people.
Yeah, definitely. And I think if you've gone through the effort of explaining a specific drop to someone, and then you're not having that follow-up appointment, then after they've bought that initial bottle of drops off you in practice and you know, gone about their merry way, you know, a couple of weeks down the line when they run out of those drops, are they going to come back to you to get the same drops again, or are they just going to go around the supermarket and say, oh, there's some drops there, I'll just grab those off the shelf there?
Yeah, this is not, it's not a one-off hit at all. I mean, I'm sure Francesca and Ros will tell you more about, you know, I mean, they already have, they said they have a follow-up appointment, but they'll tell you more. But for me, it probably took 3 appointments, I think 3 or 4, and that's on top of everything that I know. So 3 or 4 actual consultations where, you know, we examined my eyes and we talked about what the different options were. And initially we were concentrating on blepharitis, So I think I've had blepharitis for a very long time. I mean, I've had a bit of dry eye for a very long time, but it's always been manageable. But then a year ago in May, so almost a year ago, just overnight, my eyes just went like that, just really dry, really sore, much worse than before. And you know, my blepharitis was worse than before. I could see it was worse. I could see just by looking in the mirror that I had bad blepharitis. So the initial treatments were about controlling that. And once that was under control, then subsequent were about dealing with the aqueous. And it's interesting, you know, we mentioned the JUICE-2 report, and the JUICE-2 report, prior to JUICE-2, there were two definitions of dry eye. There was the NGD blepharitis dry eye, and then there was the evaporative dry eye, which was to do with deficient aqueous. And the JUICE-2 actually said, you know, they're not separate from each other, they're just a scale, and people are in a different place on that scale, and some people might be more towards aqueous deficiency and others will be more towards blepharitis. But they exist in combination, and that's been absolutely my experience, is that I think I have an aqueous deficiency caused by Sjogren's syndrome, and that made my blepharitis, which pre-existed, a hell of a lot worse.
Mm-hmm. Yeah.
So does that mean you can cut an onion without crying?
Yes. Yeah, that's one of the advantages. Yeah, I mean, it still stings. So I think, you know, I think onions are not quite what they used to be. So when you buy an onion these days, it isn't as stingy in the first place as onions were when I was a child. But yeah, if I grow my own onions, or if I get a nice, really fresh, juicy onion, then I can chop it and it stings my eyes, but my eyes don't water.
And that's why I have to cut all the onions in my house, because I'm the only contact lens wearer. Great for cutting onions.
Yeah.
Do you know if you cut the ends off the onion, it doesn't make you cry? If you cut both ends off.
That's rubbish.
Rubbish.
Yeah, it's rubbish. I did that last night. It didn't work, mate.
It works for me every time. Maybe I've got a dry eye issue I don't know about, but who knows? Who knows?
Once all this is over, come in and see me, Stuart, and I'll do an assessment on you, and I promise I'll do a follow-up as well.
Sounds like a plan. Sounds like a plan. So let's talk a little bit about dry eye clinics then. So what kind of advice would you give to practices in terms of setting up a dry eye clinic? What kind of benefits are there to the practice, and how would you sort of go about it?
Ros, you start.
Okay. I think. Look, when somebody comes in for a site examination, you probably see them once every 2 years. I'm assuming. We see them once every year, but with a dry eye clinic, you do kind of instill more of a following, because you see them a lot more often, and you have a much better relationship with that patient, and they're not likely to go anywhere else. And because it's not something that's measurable as such, it's something that actually just makes you feel a lot better and makes your life a lot more comfortable. There's so much value placed on that. And I ignorantly, I mean, I did it from a contact lens point of view, but I didn't do it from a dry point of view initially. We now have a specific dry clinic. I didn't realize the value of that. I mean, my clinic is fully booked 3 weeks in advance. I work 3 days a week, and 70% of it is dry eye. Okay. And the value of that clinic, from a patient loyalty point of view, nobody really goes out of my clinic unhappy. They're always coming out smiling, and they're always, you know, they have some of the most uncomfortable treatments, like Blefex, but yet they're coming back because it feels so good and it makes them function in life. So the value you're building into your business is incredible. That's one thing. Secondly, it's really satisfying as a clinician. So back to your point, Fran, that actually it's a really nice feeling, because you're actually making a positive difference to somebody's life in a really nice way. Thirdly, it's kind of nice for the whole practice team to feel like they're behind something that is actually pushing things in the right direction. We do something very different to a lot of our competitors, and everybody really quite likes that as well. So it builds a real nice team spirit, but it's just the fact that you're really making a difference to somebody's life. It's not life or death. Definitely not. We're not in a situation that we're in now, nothing like that, but it's making a real difference to the quality of their lives. So that's really good from your own point of view, but it's also financially, if you're looking at it from a financial point of view, it's made a very big difference to our bottom line as well, without a doubt.
Yeah, definitely. I think one thing people, I mean, if anyone wants to introduce anything into practice, they want to know that it's going to help it with, in terms of bringing profit into the practice. Otherwise, it's not viable to do, is it? So that is, you know, an important part of it. But like you say, just the fact that you're making your patients' lives better, you're improving their quality of life is a huge thing, isn't it? And that will go a long way to building your patient loyalty.
And I think you can't decide who's going to spend what on. I mean, I know what you're saying, Fran, that I work in the City of London and, you know, money isn't an object, but you still have to you still have to justify why you're charging them whatever you're charging them. So they're not going to come back if they don't feel like you're doing a good job. And actually, word spreads very quickly that you aren't doing a good job. So yes, the money is probably there to be spent, you're right, but you have to know what you're doing and you have to be able to substantiate what you're doing. Otherwise, the whole area is going to know that don't go in there, because they will just rip you off or they don't know what they're talking about. So you do have to be on your game with that. So that's really important, and you can really do something with this, without a doubt.
Do you think
I would agree with that.
Sorry, Frank, carry on.
I would agree with that. I think there is definite room for dry eye clinics, as I say, but I think it also depends on the demographics of your patients. And I know I have a lot of friends and colleagues who have very, very successful dry eye clinics up and running. I worked in a practice that had a very successful dry eye clinic, but now they have introduced MECs into the area, so they can actually now do their dry eye clinics under the MEC scheme. So the fact that they had already got that up and running, but what they can now offer are the extras like the BlephX, like the LipiFlow. And I think if it can be run in conjunction with community eye care services or MEC schemes, then that's even better. But I think a lot of practitioners really need to be convinced that it's worth the initial outlay, it's worth having those appointments, because the practice that I worked in that had that, it was all a bit hit and miss. Some weeks we'd maybe see 2 or 3 patients, but again, it was always that grudge purchase of, I'm paying for an appointment that isn't going to help, is it going to work? Yes, once they realised it was working, then that's a different matter. But I think, and I'm not, you know, being, I'm being devil's advocate, and I'm not saying yes, but, because I know a lot of practitioners can be like that about a dry eye clinic. You know, if I had my way, I would be doing dry eye clinics in everybody's practice. But in some, no matter what you do, there are some areas that patients are just not going to spend the money on those appointments and on those treatments if they feel they can get their hypermelos, their artificial tears from their doctor.
Yeah, no, I can see that. Sorry to cut in front. I can see that. And I think also, if you think about a dry eye clinic, it doesn't follow the pattern of an optician's practice. Like, everything is measured in an optician's practice. You know, you're coming in, you have your pressures measured, you have your cut to disc ratio, you see this, you know, it's 6/6, it's a PD, everything's about measurement. And suddenly, at the end of this appointment, you're being given, here's an eye bag. And it's like, that doesn't fit. How does that, I mean, that's a complete step change. And there is nothing measured about that. There is nothing, there's nothing black and white about it. And the rest of the whole process is, and that's why this is so difficult. So I agree with what you were saying. It's so difficult to set up and put together initially. But once you've got the buy-in, and that's why I do think it has to be a separate appointment. And we've done it so it's actually a different clinician as well, which is probably where I come in, because I'm a contact lens optician. I do think it has to be somebody different that is delivering that information, if you can afford to do that as a practice. And if you can, you know, we had to take a bit of a gamble when I went to the eye place, because there was no contact lens clinic, there was no dry eye clinic, there was an empty room with no, and I was seeing 1 patient a day, and it was like, okay, we've got to make this clinic work, and I'm going to float you for 2 years to ensure that clinic works. If you haven't made it work at the end of that, then we have to decide what we're going to do with you. So it was a bit of a gamble, you're right. And it's such a different process to the rest of a site examination, a dispense, a contact lens fitting, everything. So yeah, you're right, it's a gamble, but I guess I'm really passionate about it as well, and I've made it work in an area that the demographics are probably right as well. But having said that, we do have practices in Sheffield where it's working really well too. So I think I just don't think you can know who wants to spend what on their eye care or their eyes.
Mm-hmm. Yeah.
If I can add to that, I mean, just from my experience, it has been trial and error, and I think we talk about dry eye clinics, and we talk about having to know what you're doing, and we talk about BLEFX and IPL and things like that, and yes, I think if you've got a successful dry eye clinic, these are treatments that you're going to offer, and patients will pay for them. I think if we're talking about somebody who's just working in practice and they've not done a dry eye clinic before, and they maybe don't even have they don't even have the ability to decide that we're going to do a dry eye clinic, because they're not managing a practice, they're just working in a practice, maybe a locum, maybe an employee. I mean, I don't think that stops you addressing dry eye, but I think what Ros said about it is quite a different process to what you normally do. So what you normally do has some real scientific hard facts and figures, and aside from osmolarity, which again I guess is a thing that you're going to be doing if you've got a dry eye clinic, because you've got to purchase the osmolarity testing machine. Apart from osmolarity, the rest of it is all just trial and error, and have a look. If they've got blepharitis, do the things that we know that treat blepharitis. So that's lid hygiene, that's eye bags. If they haven't got blepharitis, or if you get on top of the blepharitis and that hasn't helped, then try some eye drops. And then try some different eye drops, and alter the frequency of the eye bag, and try a different lid wipe and things like that. So I think the cost to the practitioner is about the time, and it is an investment in time, and it's not just something that you can take a quick measurement and say, here you go, that will work. So you do have to work out how you're going to pay for that extra time. But if you've got some extra time, I don't think dry eye is a particularly difficult thing to manage. I think it's just something that you need to get used to working through in a methodical way, and trial and error.
Do you think there maybe are some practitioners out there, some of whom might be listening right now, they're afraid to address dry eye? They're worried about giving the wrong information, the wrong drops, not referring when they should be referring? Do you think there might be an element of that?
Yeah, I think so. I think if we talk about dry eye clinics and specialists and things like that, obviously we need those. In the same way that you have people who specialise in contact lenses, and we have specialist contact lens clinics. But the rest of us do contact lenses as well, and there's no reason why we can't, have a go at dry eye. And maybe, we have a go at dry eye, and if we can't solve it ourselves, we can refer it on to somebody like Ros. I know there are all sorts of, competitive issues with referring to competitors and things like that. But, for me, if you're not sure about managing dry eye, don't think it's complicated. Start with the basics, keep it simple. Try lid wipes, try eye bags. Once you've got blepharitis under control, then try eye drops and try different ones. And that's pretty much what I did on myself, and it worked.
And can you tell us what works for you, or would that be advertising?
Yeah, I don't want to get into which ones are my favourite eye drops. Because I genuinely, it'll be different for different people. So I think my dry eyes, I don't really have a raised osmolarity. So due to, definitely talks about osmolarity, and even you will get ophthalmologists and dry eye specialists who will talk about, well, when you get to this osmolarity, you do this. When you get to this osmolarity, you do this. I'm not sure that's right. I think that sometimes affected in people, but not always. And I think it's variable. It's a bit like IOP with glaucoma. some people have raised IOP, some people just have a more variable IOP, and that's my, not basing that on sound evidence, so don't quote me, but that I think is what's going on. So my osmolarity is fairly normal, and so some of the eye drops are designed to bring your osmolarity back down again. And if I try those eye drops, they sting when I put them in.
Yeah.
And so I don't use them because they sting. And actually, they sting for quite a while. It's not just when I first put them in that my eyes are then uncomfortable for 10, 15 minutes after I put them in. So I prefer the ones that are not trying to reduce your osmolarity, and they seem to work better. Hyaluronic acid works well, but then there are some drops that have got hyaluronic acid in that don't seem to work any better than ipromelos, and there are other ones that have got, I think it depends on the molecular weight of ipromelos, but it also depends on the way that drop is prepared with the ipromelos. I don't think it's just molecular weight, or just even the concentration of ipromelos that there is in that drop. I think it's more complicated than that. I'm not sure that anybody really knows. So, I've tried, there are some companies that make hypromelos in different concentrations, and I've tried their different drops. And for some of them, I just can't even tell any difference. So, the 1% is no different from the 3% for me, but it might be for other people. But hypromelos, hyaluronic acid definitely seems to work for me in an eye drop. I quite like eye drops that have got a little pump rather than ones that are in separate bottles. So the ones in the little separate packets, I mean, they work. It's more of a fiddle. And then I always feel like I'm throwing some of it away, and I'm throwing lots of plastic away, lots of little bits of plastic away. Whereas if I've got a pump, they just seem to last forever. I mean, those ones, the drops with the pump, I mean, I open those and a month later, they're still going. Most of the drops I get in my eye, don't always get them in. Sometimes they dribble down the side and I have to put another one in. But most of them I can get in. It took a little while to put drops in on yourself. I mean, you used to put drops in on other people. Putting drops in on yourself took a little while to get used to. I use an eye bag. Initially, I was using that twice a day. I now use it once every 2 or 3 days. I prefer eye bags with a strap. Partly so you can just be standing up or do other things. I'm preparing for when I go blind, when I get properly old and I go blind. I walk around with my eye bag on. I make cups of tea with my eye bag on. Just put my finger in the top of the cup of tea until my finger burns. And I'm practicing all of the things that I've told people to do who've got low vision before. But yeah, it's not just that you can move around as long as a strap. I think, how you do an eye bag and then you massage your eyelids to get the meibomian secretions going. I think the ones with the strap, if you tighten the strap, I mean, obviously not too tight, but you just tighten it a little bit, that expresses all that meibomian gland fluid because of the pressure. And I find if I use the ones with a strap, my eyes feel much better the next day than if I just use one that doesn't have that added pressure, that expressive pressure. So that's just me. I've got an eye bag that works off a USB port as well. So you don't have to put it in a microwave. If you go away and you stay in a hotel, I know none of us can do that at the moment, but hopefully we'll get back to doing that. If you stay in a hotel, it's a bit difficult sometimes to say, can you put my your microwave for 25 seconds for me, please? You just plug it into your power pack or into your phone charger, and it stays warm as long as it's plugged in. Yeah. And that's brilliant for traveling and going away. Probably not quite as good. It doesn't fit as nicely, all the little beads or seeds or whatever in eye bags. They fit more nicely than the USB one does. I even bought one that was almost like a visor, like a virtual reality visor. and it played music, and it had like a massaging function. It was completely rubbish. It just didn't fit my face at all. I've got quite a big bridge, and it just didn't fit over my bridge, so it was hardly touching my eyes anyway. So for me, that didn't work. For others, it might do. If you've got a flatter bridge, it might work. It was quite cool that it played music, so you could stream it.
I think from all of this, Peter, it just shows you that there isn't a single one size fits all. And I think that as a practitioner, that's what we must look at, that although you might feel passionate about those drops, just because they're your favourite as a practitioner doesn't mean it will work for that patient, or you prefer that eye bag with the flax seeds rather than the ones with the wee plastic beads. And, I think we need to have a much more open plan and outward thinking regime to all of that.
And that's why I said patient education is important, because I think telling the patients about all of the different options that are available and saying, we can try this one and see how you get on with it. But if it doesn't work for you, there are other things we can try. So don't give up. So just try that, and then it didn't work, and then you think you can't do anything else. Yeah. So I think that what having dry eye has taught me is trial and error. Is definitely the way forward.
But I think where the follow-up comes in, doesn't it? I mean, it's kind of like, well, we're using this because we've seen that you've got a low tear prism height. So it should, in theory, this particular drop on the shelf should work. But, okay, let's teach you how to put the drop in. That teach appointment's really important. And then get you to come back and let's make sure it has worked. And if it hasn't, why hasn't it? And then we can kind of target it a bit more. So back to Francesca's point and back to my point, it has to be, we've got an array of things. We've got a shelf full of stuff, but it doesn't mean you use everything. You don't just go along and pick a piece off. You've got to have some kind of direction in the direction in which you're going, and that's what your follow-up about. That's what your follow-up appointment is about, to ensure that it worked or it hasn't. A bit like your contact lenses, and exactly the same thing. Have those torics stabilised well enough, or are you getting a lot of fluctuation in your vision? Okay,
yeah, so,
it's a stabilising method.
Yeah, it's guided trial and error, isn't it?
Yeah.
So I'm saying it's trial and error, but it's guided by what you're finding as well.
Yeah, it's not you've definitely got a 125 still at 95 degrees. It's not, that's what I mean. It is not as measured, but it is definitely guided. And that's the difference. And that's why I think it has to be dealt with differently.
And perhaps that's why some practitioners struggle, because in theory, we're kind of mathematicians, but 2 and 2 is 4, that's it. Dry eye is all a bit slightly holistic, a bit like yoga, a bit,
Yeah, I completely, I mean, that's why I kind of think it, and this is just, I was having this conversation because I did a bit of CET for our practice, and I was looking at our DOs talking about dry eye, and I was looking at our optometrists when we're talking about dry eye. And the DOs, and I think it's because we're used to kind of managing, like when you come out from a sight test and you do a handover, and here you are, here's the prescription, and I think this person should have varifocals. And the person who gets fitted with varifocals, the ones that we've decided is good for them, for whatever reason, a slightly wider corridor here, or, a bigger reading portion, or whatever it happens to be. And then the patient comes back and they're not kind of like 100% happy. And we go, actually, we're just going to change the angle of the glasses to bring, the reading portion in a bit closer, and now go away and try it. I think DOs, CLOs are a little bit better at dealing with imperfection. That's kind of how our training is. Whereas for optometrists, it's very specific, or a lot more specific. And I kind of picked that up from the CET, that our DOs didn't struggle with it as much as our optometrists did. And maybe that's just because of the way that your day works. I don't know.
Yeah, I think you bang on. I think, as an optometrist, you want that there is a right and a wrong answer.
Yeah.
It's either this or it's not, or it's
either better or worse.
Yeah.
Whereas for me, it's never, is it better or worse? It's always is that better than it was last time? Is that livable? Is that more comfortable? The obsession with infinity, I just don't understand. Well, I will take your prescription and go, yeah, but you spend most of your day working on a screen. Let's just not go 50 off that. And I think we're better. I think just because of the way that we're trained, we're actually set up a little bit easier for it. We're better with dealing with the imperfections of it all.
Well, that's why I said that the analogy with varifocals or contact lenses is good, because I think it does feel more like that. So varifocals, you know, there's a range of lenses that you could use. You try them; they don't always work for everybody. Same with contact lenses. You've got a first round of lenses that you try, and if they don't work, you try different lenses, or you vary the solutions, or you make small tweaks and changes. Whereas that's not like prescribing a pair of spectacles. It's just, you know, the spectacles are that prescription, and that's pretty much it, really.
Minus 50 at 92.5.
Yeah.
You come across prescriptions like that, and that I'm thinking, how accurate, you know, and again, that's maybe the kind of practitioner that would struggle with the whole dry eye thing, because it's all a bit woolly and a bit grey, it's not black and white.
Yeah. Very great.
Talking about varifocals, I've got some new varifocals that I'm now on my third attempt to wear, and I'm forcing myself to wear them, but I just can't get on with these at all. I can't see anything. Nothing's not clear, just nothing's right. Nothing is right at all.
It's just like patient, doesn't it?
But actually, talking about vision, I mean, that was one of the things that I noticed with my dry eye was, as I said, it suddenly got worse, and I had a noticeable blepharitis, and then it started to affect my vision.
Yeah.
So I couldn't see properly in the distance. I had to blink a few times, and even when I did that, it still wasn't properly clear. That's all gone away with treatment. So the only time I get blurred vision now, of course, is straight after using an eye bag, and then it's really, really blurred, which is great because I know it's worked.
And again, that's about managing a patient's expectations. If you don't tell a patient that, you know, once all those good oils and fats start oozing out and go into your tear film, when you take your eye bag off, everything's going to be blurred. Otherwise, patients are phoning up the practice going, oh, this eye bag, I need to stop using it, it's making my vision blurred. So again, it's about managing the patient's expectations and giving them the correct advice and education.
Yeah, I mean, if you think about how thin a tear film is, you know, it's unbelievable how much effect it makes on the refractive surface. You wouldn't, if you told me that 20 years ago, I'd go, yeah, that's a load of rubbish. You know, people are just making that up. That when they've got a bit of blepharitis, it blurs their vision. You know, it can't make that much difference, but it does.
It does. It's huge, isn't it? I mean, 60% of your refractive error comes from the anterior eye, right? So it's got to, if you think about it. And it's a bit like trying to look out of a dirty window. A lot of my patients are going to go, oh my God, I've got HD vision for the first time in years. So it massively, I mean, it's reduced our recheck rate, our dry eye clinic, and our remake rate. So that's been huge as well. So it has an impact on the practice in so many different ways.
Yeah, I think if you consider the things that affect your quality of life, poor vision is definitely one of the biggest factors that can determine how well your day goes. If you're struggling to see anything and struggling to carry out day-to-day tasks of blurred vision through dryness or refractive error or varifocals that you can't get on with or whatever it is, it can have quite a big impact on the quality of life, can't it? So it's important to understand. I think when we did the podcast last week with Jayshree and Dan, one of the points that Jayshree made about low vision was that we learn about pathology and we learn about the eyes, but we have to remember that those eyes belong to a person, and how those eyes work affect how that person feels inside and how they go about their day-to-day life. So with that in mind, Peter, what kind of impact on your day-to-day life did dry eye issues create for you?
Well, for me, not a huge amount. I mean, it's really good that we raise it, because I think if you do have persistent, chronic, significant dry eye, then that can be a real lifestyle issue, not just from not a quality of life issue. And that's not just from vision. You know, if you imagine if you've got dry eyes, I wouldn't describe it as a pain, but if your eyes are uncomfortable all the time and gritty and a bit sore, and that is happening all the time, then, you know, I think that can can really get you down. And I think dry eye is associated with depression and other mental health issues. For me, it's not been a big issue. For me, probably the other things that go with Sjogren's syndrome have been a bigger issue. So as well as dry eye, I've got a really dry mouth. My mouth gets really dry and my tongue gets sore when I wake up in the morning. And I've got sore joints and sore muscles. So sometimes, some days that's all right, doesn't bother me. And other days, you know, I stand up and I'm kind of limping around because my ankles are so sore.
Yeah, definitely. So yeah, it's interesting to hear how it actually affects you as a person, isn't it? Because I think, like I say, in the test stream, that might not come up as in depth as, you know, that kind of explanation sometimes. So with that in mind, I mean, what kind of holistic approaches do you take aside from the dry eye treatment? Is there anything else that you do to combat that kind of stuff?
Regular breaks from your screen, which is easier said than done.
Yeah.
If you've got a desk job that's involved a screen, you know, it's easier said than done to get kids off their screen, both for myopia control as well. But, you know, they want to be on their screen, they want to be playing games, they want to be chatting to their friends. And I think, you know, I think even down to things like with ladies, I always say to them, when you're taking your eye makeup off, do it in little massaging motions so that you're actually massaging those tear glands and getting everything moving and going. So there's lots of little top tricks that you can do, but I would say we need to not be having the aircon full blast in the car or the heating on full blast and regular breaks from the screen. But all these they're on a wish list really, and we're all guilty of all of those things and not doing all of those things.
Exactly. I mean, I think the other thing is the omega side of things as well. Yeah, for sure. And kind of like maybe trying to look at diet. But again, it is the same thing, isn't it? These are your pleasures in life, and now suddenly you're having to kind of change them. It was interesting to see that for us in the city, a lot of the offices kind of started working from home at the beginning of March. So we sort of like our business started getting affected quite early. I mean, earlier than the lockdown, and I was obviously still in practice then, and patients were, you know, as the reminder went out, they were phoning up and cancelling, but I was still doing some phone conversations, and a lot of them were saying that it was amazing how their office environment had made their dry eye worse, and now that they were working from home, it was actually better. They were probably not as proficient. They probably weren't as efficient, but the fact they weren't sitting in a room full of 30 people in really horrible air conditioning, they just didn't find their eyes felt as bad. Mm-hmm. And they were able to get up rather than being super glued to 3 screens for 16 hours a day. They could go up to the fridge and just go and make themselves a cup of tea when they felt right, rather than having the pressure of all these people around you the whole time and not feeling like you get up. So exactly to your point, Fran, that actually we have these great bits of advice, the 20-20-20 rule, or the get up and have a break and make sure you drink the water. But does your environment really support that? Psychologically, and from the point of view that, you know, it's just not a healthy office, as in it's not healthy, the aircon's on, the lights coming in at a really weird angle and bouncing off your screen, and you can't move your desk position and all of that kind of stuff. So there's lots of little bits of advice that we can give, but actually how practical are those bits of advice to put into place?
Yeah.
And I think just recognizing, you know, as you just said, Stuart, you know, those eyes are connected to a person. And some people will have dry eye and it just doesn't bother them at all. And some people will have dry eye and they'll be quite depressed about it. And we know, as Fran's already said, that antidepressant tablets make dry eyes worse. So you've got a bunch of people who are already depressed who are now getting dry eye and getting even more depressed if they've got dry eye. So I think just being aware of that is all you need to do, really, just to be aware that there are some psychological issues with dry eye, or there can be, and just try and spot those if you think they're happening, and talk to people about them. And I think sometimes just something I'm completely rubbish about is just talking to people and listening to people who trying to describe their problems to me. I'm more aware of it the older I get, but I'm still not very good at it. Not like Fran and Ros, who are great listeners.
You should listen twice as much as you speak, because we have 2 ears and only one mouth.
There you go. Good advice. Good advice. So what other impacts do you think the lockdown is going to have on the dry eye situation in the UK?
Well, I think from Ros's point of view, that the office workers are probably in a better position because they're not glued to their screen all the time. They're away unloading the dishwasher, putting a wash on, making a cup of tea. But then you've got, say somebody like myself, for example, that's normally in practice. I don't spend, of the 8 hours I'm in work, maybe in that time I'm on a computer for maybe 3 hours of that day. The rest of the time I'm doing this, that and the next thing. But some of these days, because of different things I'm doing, watching podcasts, doing some CET, doing some research on Zoom calls with my family, I'm spending much more time on the computer, and all of a sudden I now have a dry eye problem, which I normally don't have, because it is that digital eye strain and the fact that I'm staring at a screen. I think we're on our phone more, I'm certainly watching Netflix in the evening I don't want to watch any more news. So all of a sudden I have developed a dry eye issue, but I understand the majority of Ros's patients are in the opposite camp.
Yeah, for me, lockdown has made my dry eyes worse, and I think that's partly a bit more screen work. So I've set up an office in my house, and of course, the temptation to just drop in and do a little bit extra work in an evening is very strong. But I think it's more about just being out of routine. I'm a bit out of routine, and I have a routine at work. I have my bottle of water, and I have my eye drops, and I have a mouth spray as well. And I use those, and then I use my eye bags, and I've just been going to bed later and not using my eye bags and forgetting to put my eye drops in and things like that, because I'm a little bit out of routine. I have still been able to get eye drops and things, which is important, I guess, just to point out that these things can still be delivered, you can still order them. So I'm okay on that side. But yeah, for me, it's just been adapting to a new routine. And I think I said to you guys before we started recording that talking about dry eye is a nightmare, or writing CET about dry eye for me is a nightmare, because normally I'm on top of it and I'm not aware of it, and therefore I don't feel it. Whereas we've been talking about it now for at least an hour, and I still feel good. My eyes don't feel dry.
Obviously, one thing you mentioned there, Pete, was the provision of dry eye drops. So what would you recommend practices do in this kind of situation if they've got dry eye patients that they're managing? What kind of are there?
I think you need to ask that to Fran.
Well, the practices that I have been working in, which I'm not working in at the moment because I'm self-employed, are doing a lot of triage servicing over the phone. Some of the practices I work in have a complete closed door policy, so no patient will get over the threshold. If they need the drops, the door is open. They pay over the phone with their credit card, and the door is open. The drops are put on the pavement in a carrier bag, and the patient walks away with them. As simple as that. Obviously, all pharmacies are open, so if the drops that you've recommended are available from your local pharmacist, then some people are going there as well. But obviously, we want to keep business in-house if we can, and so that's what the practices that I work in are saying to people. Don't worry, we can get them to you, just pay us, blah, blah, blah.
Where there's a will, there's a way, isn't there? I think there are schemes out there, and I think a lot of practices will have direct debits for contact lens patients. So if you're managing a dry eye clinic, would you have something similar for dry eye treatments? Is that something you'd sort of want to implement into your dry eye clinics?
I know that a lot of practices who are running dry eye clinics have, because it is an ongoing thing, they have got a direct debit set up with that kind of thing. So their drops and their renewed eye bag every 6 to 8 months will automatically come through to them. So I'd be interested, obviously Ros has lost volume, but I'd be interested to see what she had to say.
I mean, what we have is we have either a direct debit scheme, or you can do pay as you go, whatever you wish. We're still providing all drops, wipes, eye bags, whatever you want to provide. The only problem is a lot of our guys, from where I am in Fleet Street, the practice itself isn't open, but our phones are being answered, and we have an optometrist that will go in if you need anything. That, you know, we'll triage first on the phone. So if you need to be seen for whatever reason, for example, as I said, we had that patient that's been put onto, and I still can't remember that glaucoma drop. He's been put onto a non-preservative glaucoma drop, which is making his eyelashes grow more, and he's getting the eyelashes hitting his eye. So he came in because his eye was really sore, and the optometrist went in and removed the eyelashes for him. But what we are having is we're not able to post stuff out, unfortunately, because stuff isn't getting there in the post because there's such a backlog. Yeah. But if you're living close enough, then we'll get the drops and the eye bags and such like to you.
Yeah, definitely. So like I say, there's options, isn't there? There's ways to work around these kind of situations. As Fran mentioned earlier, with some of the dry eye products that you've seen, they're being seen under the MEC scheme. But given the nature of dry eye disease, and obviously the reports from the Jews report and the classification of dry eye as a disease, do you think it should come under the GOS umbrella? And do you think there should be provision for practices to provide regular dry eye appointments and follow-ups and such under that kind of scheme?
I mean, from my point of view, because that's the way we work, and that's the only way that I can see a clinic being successful, because it is so variable, you know, and it moves throughout the year. And to Peter's point, even though you're going in a guided direction, you've got to make sure that guided direction is actually working. If it was supported by the NHS, I think it would make a massive difference by the GOS. It would make a massive difference. It would make a massive difference to the amount of people that they're getting turning up at A&E. It would make a massive difference to their workload, and we're ideally placed to manage this. We really, really are. So I think we should be taking that burden away from them. And if there's a system behind it where, you know, you have your initial and you have a follow-up built in, that would be really useful. And I think that would also give a very, very good blueprint for practices to work on, even if they aren't being supported by the NHS. If it's privately, it would just give that blueprint. It would endorse what Dues 2 is saying. This is the process that you need to go down. So the whole thing would be tied together a lot better.
Yeah, I would agree. I mean, I'm working in two areas that have different MEC schemes, but very efficient MEC schemes. We're being remunerated probably fairly adequately for what we do, but the savings that have been made have been fantastic. I would say that 80% of the MECs that I do is a dry eye problem, some more severe than others. What's been very interesting during this period, where we've been triaging over the phone, the patients that we have sent to Eye Casualty, one of which is BMEC in Birmingham, they're in and out in less than 2 hours, because actually BMEC are only dealing with real eye casualties, and they're not getting all the rubbish that normally just rocks up and turns up, because so many more patients are being triaged over the phone, being dealt with over the phone, and they're not just turning up willy-nilly. So actually, from that point of view, if you are sending someone to Eye Casualty, it's such a smooth operation now.
Yeah.
So that's a bonus, and maybe it will make the CCGs realise that we are great people to have out in the community. All these people don't need to be continually seen in eye department clinics, when it's things that we can do. So we have to look at, when we come out the other end of this, there's got to be some positives.
Yeah, I agree.
Yeah, definitely. And I think anything that we can do that is of a more clinical nature, and like I say, we've touched on the subject of how dry eye affects mental health and all the rest of it, and quality of life. So it's an important thing to manage. So, you know, it does give us a bit more of a clinical standpoint rather than the retail side of our profession. So it does give us that a bit more gravity when we're sort of arguing the case for better funding from the NHS, definitely. So I think that pretty much wraps it up, because we've done quite a lengthy discussion on dry eye today. So it's been really interesting. So thanks for everyone for taking part. I hope everyone's enjoyed listening to it. I've certainly enjoyed taking part in the discussion. We're going to be back soon with another one about myopia control, which again is another massive topic that's going to be a huge part of optics, going forward into the future. So that's going to be really something to look forward to. So yeah.
So on that note about myopia control, and I'm just going to throw this out there, with all this, with more kids being on screens, smartphones, computers, outdoors a lot less, playing a lot less sports, I wonder if we're going to notice a spike in myopia when we come out the other end of this. I think that will be a very interesting question.
Definitely. I've got a 12-year-old who's a minus 0.75, and he's currently on his Xbox. I'm going to go and kick him off that when we finish this and send him out into the garden with his little brother. But yeah, he's due an eye test any moment soon. So I'd be interested to see if that has crept up a little bit. So yeah, we should see. Definitely an interesting point. So thanks for raising that. So yeah. So
and just one more thing. Those eye drops, Ros, are they Zioptan?
Sorry?
Was it Zioptan?
Oh yeah, that's it.
A preservative-free prostaglandin analog. I'd like to say that I knew that, but I googled it.
Oh, did you Google it? That's it. That's the one. Yeah. So Stephanie had to go in especially to remove his eyelashes because they were causing him such problem. But he's a lot more comfortable. His eyes are a lot whiter. He uses those in conjunction with some other drops that we've prescribed him. And again, we're not going to get into the endorsing anybody's drops, but generally he's a lot more comfortable and is now using his glaucoma drops very happily and has got no problem doing so.
There you go. We'll edit the bit out where Peter admitted to Googling.
And just as well, Peter, you were saying, I'm glad that you didn't have dry eye 20 years ago, because I would have told you to put a plant on your desk.
Well, I'm going to go and try that. I am actually going to try that just to see if it works.
To be honest with you, we still do say to patients, look, put big green leafy plants in your office. A, it looks nicer, and secondly, it's just nice for, it just humidifies the air a little bit around you. And
I can see that Stuart has already taken your advice.
Yes.
Yeah, that needs watering as well. So.
Well, that's it. That's what I'm going to do. I'm going to sign off and then go and have some water and take my eye drops.
Sounds like a plan.
Have a good one. It's really nice seeing you guys.
Stay safe, stay strong.
Take care. Bye.
Bye.